Hello, everyone, and welcome to Grand Rounds for the Minnesota Regional Spinal Cord Injury Model Systems, or MNSCIMS for short. Thank you so much for joining us today. So, MNSCIMS is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research, NIDILRR, Spinal Cord Injury Model Systems Program. And the purpose of SCIMS is to support innovative projects and research in the delivery, demonstration, and evaluation of medical, rehab, vocational, and other services to meet the needs of individuals with spinal cord injury. Next slide, please. MNSCIMS represents a partnership among the following institutions: Courage Kenny Rehab Institute in Minneapolis, Minnesota, the Mayo Clinic in Rochester, Minnesota, Regions Hospital in St. Paul, Minnesota, and the University of Minnesota in Minneapolis. Next slide, please. And we have some great community collaborators, including the Minnesota Spinal Cord Injury Association. We also have Unite to Fight Paralysis, Get Up, Stand Up to Cure Paralysis, the Paralyzed Veterans of America, United Spinal Association, and North American Spinal Cord Injury Consortium. This system collectively provides a multidisciplinary continuum of care for people with spinal cord injury, including emergency medical services, acute care services, acute rehab services, and post-acute services. So my name is Dr. Angela Hanks. I will be the moderator of today's session. I'm a research professional in the Department of Rehab Medicine at the University of Minnesota Medical School, and also Craig H. Nielsen Foundation postdoctoral fellow. Next slide, please. Couple housekeeping things. University of Minnesota has organized the CME for today's webinar. Please see the chat for information on how to record your attendance and claim the CME credits for attending. And please do so within 24 hours of this event. This meeting is being recorded and will be posted on the MNSCIMS website. To earn CME credit for today's presentation, click on the link in the chat. Also, due to the number of registrants for today's webinar, we've placed the phone lines on mute to reduce audio feedback, but we do welcome and also encourage audience participation using the Q&A function. But if you have any technical or logistical questions, we ask you please submit those in the chat to Dan Kelly. We extend a huge thanks to everyone who works behind the scenes to make these webinars possible. Next slide, please. The title for today's presentation is Spinal Cord Stimulation for Restoration of Function After Spinal Cord Injury. The speaker today for the webinar is Dr. David Darrow, Fellow of American Association of Neurological Surgeons, Fellow of the Congress of Neurological Surgeons, Assistant Professor in the Department of Neurosurgery at the University of Minnesota, and Roxwell Kaplan Endowed Chair at Hennepin Healthcare. Dr. David Darrow is an award-winning neurosurgeon and researcher who joined the department as an assistant professor after completing his residency at the University of Minnesota. He earned his MD and Master's in Public Health from the University of Texas Medical Branch in Galveston, and a bachelor's in Physics and Mathematics from Texas A&M University in College Station. As a clinician, Dr. Darrow treats patients with pain, trigeminal neuralgia, facial pain, and chronic pain, movement disorders like Parkinson's, essential tremor and dystonia, and neuropsychiatric disease, also epilepsy. Thanks to support from MNDrive, which is Minnesota's Discovery Research and Innovation Economy, and the Institute of Translational Neuroscience, most of Dr. Darrow's time is devoted to research and continuing the work he's doing with the Herman Darrow Lab with Dr. Alex Herman of the Department of Psychiatry, and Behavioral Sciences. So thank you so much for being here, David, and sharing your expertise with us. I will let you take it over.
Thank you so much, Angela. Appreciate it. I'm super excited to be here today. Our study, I'm going to talk about eSTAN today and some updated results, but our study is almost entirely funded by the state of Minnesota and a little bit by GUSU and some of our friends and family and philanthropic donors to see if, originally to figure out what spinal cord stimulation could do for SCI. I am fortunate enough to run two labs, the Herman Darrow lab at the university, which is focused mostly on cognition. And we use electrophysiology, direct brain recordings, and stimulation, and try to understand, what our brain does and why it does it for mostly psychiatric disease. But we use a lot of the same tools that we've developed on the spinal cord injury side to try to restore function after injury. And that's a huge part of our work at the Restorative Neurotrauma Lab at Hennepin Healthcare. I lead that with Sam Kramer, who is an MD PhD, also from the University of Minnesota. But we have a huge group of amazing people that help us run these studies. Um, we've had a lot of people in the past who've helped move this trial along, as well as a ton of collaborators that we've had over the years. So I put way too many slides in today because I just want to show you all the stuff that's going on and where we're at and what we're excited about. But I want to start with sort of where we are right now in functional neurosurgery and what we talk about at a national level. And right now, we have several new technologies, some of which are moving into spinal cord injury that we can use to really understand the circuit level biology of many diseases. And the benefit for spinal cord injury is that all these technologies, because we're the ones that are working on them in collaboration with all the engineers and physiologists, is that we can use them across diseases, and especially for spinal cord injury, where we have very specific complexities about how to restore function. And that is happening right now across several domains. The second part is that we are beginning to understand how to explore inducing plasticity in the nervous system in order to restore function, and now have FDA-approved therapies after stroke, for example, with vagal nerve stimulation to actually restore function in a chronic way that does not necessarily require long-term stimulation, but focused stimulation with our great partners in rehabilitation and physical therapy and occupational therapy. So the world is changing dramatically, as we all have hoped, at least in this front. And we're excited because this sort of platform technology is being spread out, is being spread across the board, and spinal cord injury will benefit. But we have been at this for a really long time. And when spinal cord stimulation was invented back in the late 50s, early 60s, it wasn't long before someone tried to apply it to patients with paralysis. In this case, this came from one of my colleagues who was a neurosurgeon, Dr. Cook, up in New York. And he implanted spinal cord stimulation in patients with transverse myelitis, so paralysis from multiple sclerosis, so non-traumatic spinal cord injury, and basically said, some patients are all of a sudden have restoration of voluntary motor activity. And this is published in Lancet, one of the most popular journals on earth. Now, obviously, if I wrote something like this to Lancet, they wouldn't take it anymore. But it goes to show you that people have been thinking about how to restore function for a long time, even with spinal cord stimulation. So this story has been coming about for more than 50 years and will continue to evolve, where the technology is just finally keeping up with that pace of what we want to do. So the paradigm shift really was that we have patients with spinal cord injury. Here you can see a mid-sagittal section plane of an MRI, a T2 MRI, showing extensive spinal cord injury to the mid-thoracic region of the spinal cord. And what you can also see is that the bottom of the spinal cord is all normal. And that's exactly where we're stimulating. We place the paddles below the level of the injury, and we're really trying to essentially restore the portions of the spinal cord that are controlling the lower extremities in this case. The goal is not really just to make muscles contract, but it's to actually change the physiologic state of the spinal cord, because once it gets disconnected from the brain, it starts to change its behavior dramatically, which is why we see a lot of spasticity. And our goal is to really alter the excitatory inhibitory balance of the segmental networks at the bottom of the spinal cord. And, I think diagnostically, this provides more validation of this long-standing idea for at least more than 30 years now of disc completeness, which is sort of an incomplete injury, but clinically not accessible because we've not had a way to modify it. But the main idea and one paradigm that people have been talking about is for even those that appear clinically complete, maybe they still have some residual function that we can exploit, and others, maybe not. But this is really sort of how this sort of moment was how I sort of changed my mind about how I feel about where we can head. Both of these gentlemen are more than 6 years out from injury. Both of them are AISA. Both of them don't have any spasticity when they enrolled in the trial. And this is essentially what we see the day after surgery when we're just putting in a regular off-the-shelf spinal cord stimulation with just tonic, regular old-fashioned stimulation. It does not restore any of their ability to feel. They're still AISA, but when we ask them to do things, sometimes they're able to do it. And that's a pretty dramatic difference from essentially what they had before, which is more than 6 years of inability to do anything like that. So that really changed my perspective on sort of, what the possibilities were, and very excited. And now we've done about, I think, 27 patients actually in eStand, and it's across a whole range of injuries of mostly the thoracic spinal cord, which is what the FDA approved us for, as well as a whole host of ranges of age and time since injury. That's, pretty representative. It's not perfect, but as you can see, almost everyone in our study, I think 25 out of 27 are AISA. And really for this study, these are adults with thoracic injury without, serious ongoing medical issues. So usually a couple of years out. But we see a large range of lesions of spinal cord injury, even though it seems like we have a lot of inclusion and exclusion criteria, we really don't. And that allows us to enroll a somewhat representative sample with injury patterns that are all different. We have some patients with spinal cords that look, pretty normal, and some that look, distorted and with a lot of arachnoiditis and other issues. And that's really the point. The point of our study early on was to try to enroll patients in the most realistic situation possible, which is for my patients, they've had injury for a few years. They have a family, they have a job, they need to go to work. Can we do spinal cord stimulation with their existing rehabilitation plan, with their existing family life, with their existing work life, and just add it on and see if it benefits them in any way? And that was really the design at the time, because at the time, the main feature of a lot of the trials was doing rehab. And we think rehab is the greatest thing ever, but we also know that most people can't afford to do rehab every single day for many hours a day. And so we're trying to be as practical as possible. What we've learned, the results from our study, and these are just some samples, but I want to give you a sense, is that as soon as we turn on the stimulation, we see dramatic increases in the amount of EMG activity, as you can see here, and also how much activity we can see measuring with accelerometers and gyroscopes. What I'm showing here in this upper right-hand corner is our brain motor control assessment, and that really is showing more of how much volitional activity do we see with stimulation compared to baseline. And you can see that most patients, not all, but most patients get a significant improvement in their volitional activity. And, our theory is that some patients have the ability to regain volitional movement because there is some of this discompleteness present, and some don't because they are complete. But it still seems to help in other ways that are really interesting. For example, one thing that we noticed over time that we published a few years ago is when we ask patients to move their legs in a specific way. At first, when we turn on stimulation and we look at the different muscles, in this case, it's right iliopsoas, right rectus femoris, tibialis anterior, EHL, gastroc. When we look at the pattern of how they're activating their muscles, each different synergy here, these muscle synergies sort of describe how coordinated your movements are. You can see that each synergy is just one muscle. And that's because they don't really do anything together the first time we turn on the stimulation, which means that, they're just kind of all independent. But as time goes on, from no stimulation to stimulation, you can see that some structure starts to emerge. Some of the muscles start working together, and then by the last time that we see them, which is 13 months after we started stimulation, you can see that, now there's actually a lot of muscle synergies. You only need the four muscle synergies to describe 85% of the variance in their movement. And so this is really encouraging to us. The interesting thing about it is that the muscle synergies that patients form don't necessarily look anything like the muscle synergies that you and I have. And so the way that patients are learning is all different. And that's mostly because we think because they don't really have any sensation. So they're using their visual system to do all of that kind of movement and learn how to move again, which presents different challenges. We have dabbled in trying to show some functional improvements with stimulation. Here you can see this is a bicycle that pedals itself, but it pedals itself at a very low rate and at a very constant speed. And this gentleman is pedaling over on top of that. And whenever he pedals on top of that, it registers a non-zero amount of force, or in this case, energy that he is pumping. You can see he reversed course here. So that's all him. He's more than 17 years out from injury at this time. And what you can see is we ask the patients to do two things. We ask them to pedal as hard as they can or to not pedal at all, so to not have any effort. And then we turn stim on or off, and we try that in all four conditions in this factorial design. And what you can see is the amount of energy that they produced really only changed when both stimulation was on and effort was present. And we did this specifically to show that it's not just stimulation driving these movements, it's really stimulation plus effort. So there is some volitional component to it. Even more striking for a lot of patients is the change in spasticity. And you have to recognize that spinal cord injury is extremely heterogeneous. Everybody is different. Some patients have a lot of spasticity and some patients have none. And so obviously we can't make anyone's spasticity better if it's already zero on the modified Ashworth scale. And many patients in our trials don't have a whole lot of spasticity. But for those that do, you can see this is what it looks like for the first 17 patients in the study that one of our students analyzed. And we set a minimally clinically important difference of 1 on this threshold, which comes from other studies that are done in spasticity, showing that a lot of patients are getting clinically significant improvements in their spasticity during the trial. So others are not, but it's a significant amount. Obviously, motor function is not the end all be all, and there's numerous studies to show that there are much more important things to people, and everybody has a different opinion because the community is not one voice. It's a ton of different voices, obviously. And some of the top priorities, when you just pool them across studies in this nice study from Simpson, are focused on bowel and bladder, of course, upper extremity function in patients who are tetraplegic, and sexual function, as well as pain and other things. So, it's not just all about motor function. And so we've tried our best to, at least measure as best we can what changes there are. It also depends a lot on, how far out you are from injury. As time goes on, you move from more, walking function as a priority to things like pain, dealing with pain every day and dealing with bowel and bladder function every day. Those are, critically important. And so preferences for, what functions should be focused on changes as one would expect, and with the heterogeneity that exists in spinal cord injury, since everybody has a different experience. And we're trying to do our best to take that into account. Another exciting feature that we've been seeing is, and again, not everyone has a lot of bowel problems after spinal cord injury, but it is pretty common, is to see whether or not just tonic stimulation itself, which is not necessarily focused on bowel function, improves bowel function. You can see in the first 21 patients here, how many of the patients achieved clinically significant with an MCID of 2.5 improvements in their bowel function. And you can see that over time, this seems to be sort of a slow progression and slow improvements. And we have some theories about why that's true. We think it improves some of the posture and some of the muscle tone in the abdominal walls. And we don't know whether or not you need to have any volitional movement for that. That could just be tone from the stimulation itself, and seeming to improve the amount of tone that's provided back to the bowels as they're trying to do their thing on a daily basis, which can hopefully, improve bowel function. We don't see a lot of worsening, but we do see some patients who have described some worsening over time with bowel function. We've done some work on the autonomic side with our partners from Calgary and British Columbia, and looking at whether or not spinal cord stimulation can improve blood pressure, specifically orthostatic blood pressure and resting hypotension. Here you can sort of see us doing an experiment where we look at systolic blood pressure and heart rate, and then we also look at a combination of blood pressure and heart rate called the shock index, and we tilt someone. We tilt them up and we see their systolics fall and we see their heart rate increases and we see the shock index increase. And then we turn on stimulation and then we see some of that stabilize. We tilt them down and then we tilt them back up with stimulation on this time. And we see that that seems to, generally speaking, improve some of their shock index, or the combination between their heart rate and blood pressure. And as you all know, there's now a phase 3 clinical trial testing spinal cord stimulation for the purpose of restoring blood pressure, although the target's a little bit different. And the patient population is also very different because they are selecting for patients with blood pressure problems, which is, not necessarily the majority of patients with spinal cord injury, but is a huge problem. And if you look across our patients in terms of who responds to stimulation and who doesn't, we see some inkling that, there are some, significant improvements. And this is looking at that shock index again. We see some improvements in most patients, but not all. And there's a lot of questions about this. Here's the responders on the left and the non-responders on the right. So maybe a 50%, 50% of the population gets some benefit from stimulation. But you can see, like some of the other patients, it doesn't seem to make it worse. It mostly makes it better. And so there's a lot of questions about how to optimize this and how to improve it for individuals. So the nice thing is that previously, when we looked at least the first series of patients, we really didn't see any safety concerns when we're doing spinal cord stimulation for improving cardiovascular function. And the big concern at the time, and still is whether or not, we're inducing some autonomic dysreflexia by doing spinal cord stimulation, because again, all we're doing is stimulating the dorsal column, which is all on the sensory side, and could include some of the C fibers, and that can induce some autonomic dysreflexia in a typical fashion in patients with SCI. So what we did here was we measured like arrhythmogenic events and found, in fact, if anything, stimulation seems to reduce the number of arrhythmogenic events. And that's really important because we're not here to induce a lot of that. Interestingly, even though we never set out to measure this originally, we added it on later through some of our colleagues' suggestion to look at sexual function. It's a high priority for spinal cord injury and in general across patient populations, is to try to improve sexual function. And there's really been not much published or tested. And so we have been measuring sexual function in both men and women. Here you can see in the first 14 men what kind of effects that we're seeing. And this is the impact on a scale that is not really designed for SCI, but it's the International Index on Erectile Function. And we see some improvements in some patients. We've had no way to optimize this or to figure out exactly how it works, but at least this is what we're observing so far. So mostly some positive effects when we see a significant change, although it's complicated, obviously, because of the complex physiology of sexual function and the handoff between the sympathetic and parasympathetic system that we may be affecting. Probably more, prominent now and more significant in terms of improvements is spinal cord stimulation and sexual function for women. And we published a paper and now have another one pending looking at how, how we can test and observe changes in female sexual function, the scores in this case, looking at the female sexual distress scale, and over time in a lot of patients it seems to fall over time in a significant way, far surpassing the MCID. It's not uniform, but we are seeing this as an effect of tonic stimulation, so that's really exciting. And we have a postdoc, Elizabeth, who is working on that, and also we're excited because we think we have some funding to continue this effort in a more systematic way, actually trying to identify a real treatment for spinal cord injury. So stay tuned. We hopefully will have a new trial soon for that. one of the big parts of our effort at the time when we designed the trial was my concern about optimizing the stimulation. And we've had really great collaborations with engineers, control engineers, and some postdocs putting together a platform, as well as grad students putting together a platform that really can work well for everybody. And the basic idea is, and the basic problem is that, we have these paddles, they were originally made for pain, and they have 16 contacts on them. And so you got to choose how you stimulate on them. And this is already after you've made the choice about where to place the paddles in the spinal cord, which is a whole different problem. But once you get the paddle in and you decide where to stimulate and how to stimulate, then you need to decide exactly how to stimulate and the parameters of stimulation that you're going to use. All of this is really derived from a lot of the pain work that people have done in the past and is really, unfortunately empirically driven, meaning we test a bunch of things and figure out what works and try to answer the question, can we just use the same settings for everybody or not? And really this comes down to a fundamental lack of knowledge about exactly what stimulation is doing. Though more recently, and I'll describe soon, hopefully if I can get to that in this talk, some of our insights about what we're actually doing with stimulation and where we're heading with that. But the basic problem here is that with just the spatial optimization and this paddle, the simple mathematical formula is 3, which is anode, cathode, or off, to the 16th power, which is like 43 million different settings. And then on the parameter space side, it's essentially infinite, but on a first order approximation, it's about 4 million different settings. You multiply these together and you say, all right, there's a lot to do. And at the time when we designed this, we were doing a lot of closed loop work, but in this case, there's really no way to do exactly closed loop work because there's too many outcomes that we're measuring. There's all different types of muscles that we're trying to understand what we're doing with stimulation and movements and autonomic function. And so, at the time I made the very intelligent decision that we were just going to ask patients because I think that in general, spinal cord injury patients are pretty in tune with their body, though we can all improve, but the idea was they can tell us what's changing or what's not changing. And so I cheated a little bit in the sense that I used a preference-based approach where we blindly test patients every day to evaluate different settings, and then we use that blinded randomized testing to derive a response. And it's really exactly like when you go to the optometrist. Do you like setting 1 or setting 2 better? Do you like setting 2 or setting 3 better? And then we have a couple tricks up our sleeves to really validate that. And one way that we did is we had everyone go home and do a very boring task, but it helped us to validate whether or not they're able to move and how they move their right side versus the left side. And we had at the time, one of my med students, Nick, help write this app with some other people. And then this eventually turned into an app that we bought that helped us collect all the settings as well. So the issue is, do we need to optimize first? And here's, a video of one person, and all we're doing is changing one parameter, which in this case is the frequency. So we start at 20 hertz, we keep the amplitude, the pulse width, the spatial orientation the same, and all we're doing is just increasing the frequency monotonically. And as we increase the frequency monotonically, you can see that their movements become a lot more complicated and less reliable. And so this is just one parameter, and there are so many parameters for us to figure out. In fact, we can mix these different settings together and do all different types of interleave spatial settings. But even just one parameter can be very nonlinear in its response. So over time, what we did was we put this into a optimization function where we are asking the patients to give us their responses on the settings. And as time goes on, as the months and months go by, they start to develop some patterns of activation that seem to be more and more reliable. And here you can see an example of that in one patient. You can see the areas that really don't work, and then the areas that mostly work. And we're still able to try out a lot of different settings, and you get an understanding of this response surface, which is really just a fancy mathematical way of doing what the optometrist does. And it results in sort of, across patients, we see all different types of patterns. And that started telling us that maybe, it does matter differently for every patient, what their function looks like optimally. And so we then compared and we said, all right, if we test every single patient with the same setting versus, or use the sort of global best setting across all patients, and we compare that with the best setting for each patient, what does it look like? And pretty uniformly, if we use a statistic called the Breyer skill score, which is essentially predicting how well they function, and compare the average best setting versus the individual best setting, almost uniformly the individual best setting works better. And this is important because, you can do okay with the average setting across a lot of patients, right? But you can do even better if you tailor it to them. And so that's been a big learning point, and tells us that we still don't really understand what's going on, but maybe we can capture some of that heterogeneity by hyper personalizing our approach for each patient. And by doing so, we can look over all the different pulse widths and all the different frequencies and test all these different things over time, where we're really personalizing it, and we can do so in what we think is a really safe way. We haven't really had any adverse events from the stimulation itself, despite trying a lot of different amplitudes and frequencies and pulse widths. So we were able to show that people can do this pretty safely. I think we got to stay humble though, and this is a sort of a sobering. I showed you this video before, which is the day after. This is someone who has a spinal cord injury, and they're more than 6 years out, and we see these nice movements after surgery on post-op day 1. But I want to show you a little bit of what this can look like in someone who doesn't have spinal cord injury. And this is in a study that I do for pain, also with spinal cord stimulation, and also in a completely different part of the body, in the high thoracic, the mid thoracic region. This is a patient who I program similarly to how I program E-stand patients, and I can also make him move that right foot without his own control. So I think it tells us that, we're learning more about this spinal cord physiology in humans, but this is not necessarily, going to be volitional movement in all patients. And I can make the same sort of movements in patients that don't have any spinal cord injury at all. So we're trying to use this to better understand sort of the mechanism of what's going on. However, on the optimistic side, I think what we learned during the trial is that many patients have come in telling us that after many months of stimulation, they can still move when the stimulation is off. And this is one of the first times that we observed this in one of our patients who was 17 years out from injury. And we turned off the stimulation, so this is completely off. And he has no spasticity or anything like that that can mimic this. And this is what he could do with stimulation off. Now it's still coarse, but the idea here is that all of a sudden it's possible to see these long-term neuroplastic effects after many months of stimulation that we can potentially exploit with other modalities to help us improve function. And this is really exciting because it changes how we think about the effect of changing the state of the spinal cord with neuromodulation. So here's sort of the summary shot that I think is really important to show. And just to remind everybody that generally speaking, we think of spinal cord injury as extremely heterogeneous across the different domains that we measure, but this is really what we've been going for a long time. So what we've done is we look at the different outcomes that we've been measuring. One is the brain motor control assessment, the cycling task that I showed you, the modified Ashworth scale, which is spasticity, the neurogenic bowel dysfunction score, the sexual function, the cardiac function, and then sexual function. And what we're looking at are whether or not patients had a significant improvement in each domain one by one, with the idea that if they had an improvement in 3 or more, that we consider them to be sort of responders. And it's a little bit of an oversimplification, but the general sense overall is that the overall responder rate in our patients going through all of these different outcomes is about 80%, which is really high for any kind of therapy, especially in patients who are mostly Asia A. And this is really encouraging to us, but I think it's important for people to see that even though you may have done well with getting an improvement in your volitional movement with the BMCA doesn't mean that necessarily you got the same with cycling, and vice versa. You could have an improvement with cycling, but no improvement, no significant improvement with that brain motor control assessment. And so, a lot of thoughts have been that all these things are correlated together, and there is some correlational structure to it. But the bottom line is, we are been keen about designing outcomes that are representative, that reflect the actual heterogeneity of spinal cord injury. Like I said, if you come in with no spasticity, I cannot make it better, but it doesn't mean that we shouldn't include it as part of our outcome for those patients who do have and struggle with a lot of spasticity. So figuring out how to move forward with this therapy is, really critical for representing, the patients who are in that population. The alternative is that we focus on one outcome at a time. And the challenge of that is, like, we could just look at BMCA. We have a pretty good responder rate for that, which is at least 65%, if not higher. The challenge is that it's not really representing the heterogeneity of spinal cord injury. It's sort of just picking out something that may apply to one small sliver of patients, and then, not really capturing the other things that are going to change with spinal cord stimulation intrinsically, as potential trade-offs or also potential synergies. As you can see, there could be trade-offs. We can make one thing worse and one thing better, and whether or not that's helpful is to be determined. But today I want to talk a little bit even further about our mechanistic work and where we're heading with things, because we're optimistic and excited about what we can actually learn from humans. And we've learned a lot from spinal cord stimulation to treat pain over the years. And, generally, when you stimulate the spinal cord, you're stimulating the first order neurons that are coming from the dorsal root ganglion and heading to the brain. Now, as they head to the brain, they synapse in the medulla and the brainstem. And the other end of these pseudo-unipolar or bipolar neurons is, where they're coming from the body, and actually measuring or, taking into account all the different sensory modalities. Now, for pain, we've learned that the working end of spinal cord stimulation is actually antidromic. And what I mean by that is, when you stimulate in the middle of the cord, some of the signals are going to the brain and some of them are going back to the dorsal root ganglion. And we think that a lot of the modulation for pain is actually going back to the dorsal root ganglion. So you're kind of stimulating the highway. And as you go to the dorsal root ganglion, that tonic stimulation essentially has some effects on the spinal cord itself. And it makes the spinal cord, for lack of better terms, less sensitive to some of the noxious stimulus that patients with pain may have. Now, when we're talking about motor function, we also think that we're going through the dorsal column to the dorsal root ganglion, because people have noticed that if you stimulate those dorsal root ganglions directly, or you stimulate the rootlets directly, you get a stronger effect on motor function. And in order to get to the motor side, you have to do a few things. But this is all with this underlying idea that maybe there is some incompleteness in some patients, or even in the majority of patients, because the primary mechanism of spinal cord injury is traumatic. And that also plays into this idea that there may be, 1 to 5% of fibers remaining that we could sort of trick into doing what should be happening from the cortical spinal tract. And there's a lot of mechanisms to sort of rule out here. As you can see, if we're stimulating the dorsal root ganglion, you can see the signals can come into some of the rex of the lamina. They can synapse on the wide dynamic range interneurons, and then on the motor pools, or they can bypass the wide dynamic range interneurons and just directly stimulate the motor roots, which happens a lot with, reflexes, when you're, pulling your hand or your leg from something hot. These are all built for that purpose. And so our job is to try to figure out sort of how we can tease that apart. And one way that we've started to be able to do that is by measuring the stimulation pulses as they're actually traveling through the dorsal column. And this is called evoked compound action potentials. These evoked compound action potentials, once you stimulate in one area, you can measure on the other electrodes where they're heading to. But the main idea is, for pain, it allows us to track how much of the spinal cord we're actually recruiting when we're doing stimulation. And that's been a problem because, we don't know exactly what the dose should be. That's some of the optimization stuff that we've been doing. Now, in order to do so, you need a pretty sophisticated system that can record these potentials very carefully. You may stimulate down here on contact 7 and 8, and then measuring on all these other areas, but there's a lot of contamination from the stimulation artifact, and you're following these very fast signals that are traveling to the brain or traveling down the spine, and you're trying to capture them, and they're really tiny. So there's a lot of stuff to do, but we can do them. So what we're seeing is on these paddle electrodes that we use, you can stimulate down in this bottom right-hand corner, and actually on all these other electrodes, channel 1, 2, 3, 4, 5, 6, 7, 8, you can see all these channels labeled. You can measure really beautiful evoked responses that change as you increase the amplitude from 0.5 up to 10 milliamps at 150 microseconds. You can see how these amplitudes grow. And basically, if you take the area under the curve, it tells you how strong the stimulation is and how many neurons you're recruiting. That's sort of a rough estimate. And as you do this, if you ramp these up, what you also see is eventually, as you get high enough, in this case, somewhere in the 3 to 5 milliamp range, you actually start to see muscle activity being evoked. And you can see here that as you increase the stimulation, it does not necessarily lead to a bigger muscle activity. It grows and then it falls. And so you can see there's sort of an optimal range for how much evoked response you're getting in the muscles. So in our patients, we basically do this over a bunch of different amplitudes and a bunch of different frequencies, because we think that if you're going through those wide dynamic range interneurons, that we're getting some frequency encoding, and that's what our work is essentially focused on here. It tells us whether or not we're going through these wide dynamic range interneurons and how so. Some of our friends have previously published that as you increase the frequency of stimulation, the size of those evoked responses actually goes down, and it goes down according to this shape. But when you ask patients who don't have spinal cord injury, how strong the stimulation is, it actually goes up as you increase the frequency, because their perceived amount of stimulation rises with all the sort of summed pulses that are coming through. And so the main question is, well, how can this be so? And so what we've done is we look at the recruitment curves here. This is 2 hertz and 12 hertz and 38 hertz and 72 hertz. And you can see, sure enough, as you increase the frequency of stimulation, you start to see a reduction in the amplitude of each pulse on average. And that's because we think it plays into part of the refractory state of these neurons. And so then you can start to do sort of these recruitment curves and look at how it changes with frequency and how big those ECAPs actually get across those different frequencies. And it's not perfect, but if you kind of, zoom in to some of these areas, I know I'm running out of time, we can start to get this sense of, what's going on here. You can see that 72 hertz takes, more amplitude to recruit the same number of neurons, at least in terms of the evoked response. But what we can also see is the motor recruitment. And when you're recruiting these muscles at 2 hertz versus 12 hertz versus 38 and 72 hertz, the number of muscles that you can actually recruit drops dramatically. So if you program someone at 72 hertz, you're probably not going to get much of a muscular response, even at some of the higher amplitudes. And this is what those muscle recruitment curves look like across different patients. But generally, they follow this pattern that, as you go up higher and higher in frequency, it's less and less muscles. And this is a similar way to show it across patients. But when you actually plot those muscle recruitment curves or those thresholds, I'm going to zoom in on one in particular so that it's a little easier to see. At 2 hertz, we start to see a motor threshold for one muscle, at this case at like 1.3 or 1.4 milliamps. So here's where it crosses. And then similarly, the same muscle for 12 hertz, it takes more than 2 milliamps to recruit. And we started noticing that maybe these ECAPs are actually explaining, because this is the ECAP amplitude, the ECAP amplitude might be explaining crossing these motor thresholds more than the actual amplitude themselves, because at the higher frequencies, they never really achieve this threshold, and they never actually activate this muscle. So this has led to this theory that we're exploring, which is essentially that the amount of energy that is needed to get from the dorsal column side, the sensory side, to the motor side through those wide dynamic range interneurons actually relates more towards synchronization of the pulses. At higher frequencies, they're less synchronized because there are more pulses basically, and their refractory states of the neurons actually play a huge role in which neurons are being recruited for each pulse. Whereas at lower frequencies, you're basically, causing all the neurons to fire in high synchrony, and that's actually making it through those wide dynamic range interneurons over time. So it's giving us a little bit more information about how do we actually evoke motor responses and get patients closer and closer to being able to sort of control that motor function themselves. So we think that, what we've observed is that sure enough, increasing the frequency increases sensation in those who can feel and decreases muscle activation. But we think that just measuring the ECAPs themselves better explains those motor thresholds than just the amplitude of stimulation. And that maybe ECAPs could help us figure out sort of this mechanism for spinal cord stimulation. We've been very lucky to publish a lot of papers on the outcomes from eSTAN and continue to try to do so to serve the state of Minnesota for what they've asked us to do, which is to answer this question about what tonic spinal cord stimulation can do for patients with SCI, and thankfully we've been given that opportunity. And I think as we continue to learn, we see that yes, spinal cord stimulation can improve function across a variety of domains. Remember, this is just regular old spinal cord stimulation. We think it's safe. It has a track record of safety. It does seem like it's best to personalize it. And, the best way to do that is with kind of a modern app-based approach that we found so far. But commercial off the shelf parts for stimulation seems to work. It can be done, and I think it provides us an excellent basis. Feel free to email me or visit our website for studies that are available. We have a few more coming online that are related, or interact with me so that we can continue the conversation about spinal cord injury and what we can do for translating for the future. Thank you.
Thank you, Dr. Darrow. That was an excellent presentation. We have 3 questions already in the Q&A. So let's go ahead and start firing those off so you have time to respond. So from Dan, what are the ethical or clinical burdens placed on the research team, particularly regarding ongoing STIM parameter optimization, long-term device maintenance, and participant safety monitoring when transitioning individuals through the completion of a STIM trial to everyday life?
Yeah, that's a great question. I think there's a lot of, considerations for that. And they're sort of like similar to how it works on the clinical side of pain as well. Thankfully, in a lot of these studies, previously the FDA has required studies to remove the device at the end of the study. And we were able to sort of skirt that and let patients use it. Our big issue is that when we started this study, there weren't any rechargeable batteries. And so most of the patients who chose to keep their device, which has been all of them, but one, they have had it replaced outside the study. And it's one of the worst parts of the study is having a conversation to make sure that people understand that these batteries don't last forever and the devices don't last forever. I'd say that in the long run, because it's a long study, 13 months or so, patients get pretty used to how we go about the optimization and do pretty well from that perspective, but there's a lot of heterogeneity. So I think we're still learning on the, we're hopeful that we're going to move everything over to rechargeables for our next study, which we are. And we're hopeful that that gives you at least 10 to 15 years of battery life on average, which is a little bit more palatable. And thankfully, the pain community has been pretty supportive and, replacing batteries as needed. So it's, I think it's a mixed bag, and it's challenging, to do research these days and think about, all right, well, if we put in a stimulator, how do we worry about 25 years from now for patients and doing the right thing, and getting that funded, in this day and age. I will say that we've applied for a zillion grants, and I will tell you that NIH does not have a strong appetite for translational things like this because they feel like it is up to the medical device companies to get this across the board because they're the ones that benefit. And if you talk to the medical device companies, they say it's not a big enough market, so we think NIH should do this. And so we're sort of caught in the middle on how to convince. I spend most of my time, I think, trying to convince both sides that this is worthy cause and that it's not too small a market. It's just big enough, but we should also have some scientific supports to move this forward so that, the collective group can really contribute to how to do this well.
Have you done any qualitative work around that to help boost your case, if you will?
I, you know, we're not like the best mixed methods sort of group. We have tried to start doing some focus groups, and we've had some spontaneous things happen with patients who just wanted to like help us move the needle with using their voice. So we've had, thankfully UTFP has tried to push forward with some FDA listening sessions because we have this issue with the outcomes.
Mm.
You go to the FDA and you say, okay, we want to do a study on spinal cord injury, and they say, okay, you're going to use INSCI, right? And we say, oh
Mm.
yeah, sure, INSCI, except no, because INSCI was basically derived for a very specific purpose, which was to reflect the natural history of spinal cord injury, traumatic spinal cord injury, right? And so you take someone from an A to a C because they have some movement and flickers, and then everybody's like, that's not fair, you're cheating. That's the kind of feedback we get. And it's like, okay, well, I don't know. Like, I know we didn't improve their sensation, but how else do we describe movements? And so we come up with all these other metrics to describe how people are moving and try to reflect that. And the FDA says, yeah, none of this stuff has been validated. I'm like, okay, well, how do we validate this? So it's sort of like a circular, how do we pull ourselves up by
Yeah.
our bootstraps sort of approach. There's no MCID for, cycling. There's no
Yeah.
MCID for EMG activity. There's no MCID for almost anything in spinal cord injury. So it's
Yeah.
it's a real challenge. But we're still pushing.
Thank you. All right, we have a few more. Let's see. Dinesh says, can you please comment on surgical epidural stim versus transcutaneous spinal cord stim in terms of outcomes of prognosis, especially when devices such as ARC-X are being used off-label for T-level injuries?
Yeah, I mean, I don't think there's enough data to say a whole lot about that yet. We originally participated in ARC-X even before it was ARC-X. And I think it's interesting. I think it's just another tool that has its pros and cons. I think the pro of ARC-X is you get broad activation across a lot of the spinal cord. But you also get a lot of activation across the peripheral nerves and a lot of other things in the back. So I think it's a great modality, especially since we've never had anything approved for chronic spinal cord injury. So it's worth trying, especially because it's focused on cervical injury. That's its labeling.
Mhm.
Um, I think implantable devices, have their pros and cons. Cons because there's risks associated with having surgery, but pro because it's targeted, and so it really allows us to personalize therapy. There's not a lot you can do with transcutaneous to personalize therapy. You just sort of get what you get. But I think these are very complementary things, and I think all of us are hoping that one day one leads to the other, and there's some sort of synergy there for what a landscape of treatments for spinal cord injury looks like and how we sequence them. But I think it's a great modality. We're trying to run a study with it ourselves, and we're excited about it because it's just another modality. But I think they just will, in the long run, have different uses.
Let's see. David asks, do you think that studies of the synergy of spinal stimulation, other specific interventions targeting individual SCI problems are ready to happen now? Or do we need to further standardize and understand stimulation itself before branching out?
Yeah, so that's a great question, and it's sort of the classic bandit problem, right? Do you do only one thing or do you do everything at once, And I think if we wait to figure out exactly what stimulation does, we may all be, dead by the time that we answer that question. And I have mixed feelings about it. I think we should do both at the same time. I think there are some things that have pretty good data for them, like spasticity. There's a series of studies in the early 2000s that show that you can get spasticity results. So there are some populations where there's some good data already. But I think in some sense, it's probably best to have kind of shots on goal in both areas because I know I have a lot of patients that want therapies now and are willing to move forward. And then I have a lot of patients that will never have an invasive implant put in for their injury because it just doesn't really matter to them. So I think, it kind of responds to what the community wants, which is everything.
Thank you. I think this is going to be the last question. I know there's a couple more, so if you don't get the opportunity to have your question answered, you can always email Dr. Darrow later. But so this is a question from Dean. I'm a T11 and I have found most studies don't include that level. Why?
Sure. Yeah. And originally it was because some people placed the electrode at T11. And so if you have an injury at T11, one, we know from a variety of reasons that patients with lower motor neuron injury don't respond to stimulation at that level because there's nothing to stimulate. And so that's been pretty clear from some of the early studies. But two, it's just whether or not we can actually get the paddle there. And so I think early on, it wasn't us, but other people set the threshold to T10 because the paddle can sit anywhere between T11 and L2. And so, depending on where your conus is of your spinal cord, which has a bell-shaped curve around L1, it can be up to T12 or down to L2 or whatever. That sort of determines where the paddle goes. So that's the reason why it is right now. I know people are using off-label transcutaneous stimulation, just like people have said, and it doesn't mean that you wouldn't qualify for the actual treatment if we can, get it across the board.
Yeah. Dr. Darrow, if you wouldn't mind throwing up that last slide,
Sure.
please.
Yep.
Again, thanks everyone for attending today's grand rounds. This was an excellent presentation. Again, I apologize if not all questions were answered. Please do reach out to Dr. Darrow directly if you want any follow-ups regarding your question. Again, this recording for the webinar will be posted soon on the MNSCIMS website with a link to our YouTube channel. And as a reminder, please see the chat for information on how to obtain CME credit for attending today's webinar. And at the end of the webinar, a brief 3-question survey will pop up. Please leave your feedback. We'd appreciate it. And we thank you all and hope you have a great rest of your day.
Thank you.
Thanks.